So this is Chapter 36, Antihistamines, Decongestants, Antitussives, and Expectorants in ATI. This is Chapter 18. For your pharmacology book, this starts on page 575. We're going to discuss antihistamines, decongestants, antitussives, and expectorants, how they work, what they're used for, and then, of course, like always, we'll talk about nursing implications for these drugs. So first let's talk a little bit about the common cold, so you have a little bit better of an understanding. Common colds are usually caused by viral infections, so the rhinovirus and the influenza virus are pretty common. Viruses then invade the tissues and the mucosa of the upper respiratory tract, causing a respiratory infection. Excessive mucus production then results from the inflammatory response to this invasion. Fluid will drip down the pharynx or back in the back of the throat into the esophagus and the lower respiratory tract, and then that causes those cold symptoms like sore throat and coughing and upset stomach as well. And then irritation of the nasal mucosa will trigger sneezing, or the sneeze reflex, and then mucosal irritation also causes the release of several inflammatory and vasoconstrictive substances which dilate the small blood vessels in the nasal sinuses and then cause nasal congestion. Treatment of the common cold usually involves combined use of antihistamines, nasal decongestants, antitussives, and expectorants. Treatment is symptomatic, so it's not a curative, it's just to take care of the symptoms. Of course, if you wanted to have some type of curative thing, you'd have to start on other medications. And then just remembering, symptomatic treatment doesn't eliminate the causative pathogen. So again, if a viral infection, then you'd use antivirals, or if it was a bacterial infection, then you would need antibiotics. So sometimes it's difficult to identify whether the cause is viral or bacterial. So they'll do what is called empiric treatment, which is treating the most likely cause. So they look at the symptomology, they see what is typically happening, and then based on that pretty typical presentation or set of symptoms, they'll treat what they believe that it is most likely. So again, that's empiric treatment. So antivirals and antibiotics may be used, but a definite viral or bacterial cause may not always be easily identified. So drugs that directly compete with histamine for specific receptor sites are antihistamines. There are H1 histamines that mediate smooth muscle contraction and dilation of the capillaries. And then there's histamine 2s or H2s, which mediate the acceleration of heart rate and gastric secretions. And then the drugs, the antihistamines, would be H1 or H2 antagonists. So H1 antagonists are commonly referred to as antihistamines. Some examples of these are Allegra, Claritin, Zyrtec, and Benadryl. And then there's, so they're antihistaminic, which means that they compete with histamine for receptors, blocking the inflammatory response. That is a major factor in allergic disorders, such as hay fever or dust allergies or things like that cause that allergic rhinitis. It's also helpful, they can also be helpful in anaphylaxis and angioedema and urticaria as well. And there are also anticholinergics, which affect secretions of the lacrimal glands, salivary and respiratory mucosal glands. And then as far as sedative effects, each drug varies in the potent-histamines as well. So they can be antihistamine, they have antihistamine blocking, anticholinergic to dry everything up,
and then they also potentially have a sedative effect, depending on the class of drugs. Next, we discuss pulling drugs antagonists. So, helping the action of histamines at the receptor sites. H1 antagonists compete with histamine and for unoccupied receptor sites, so they can't push off the histamine off a receptor where it's already bound. But what they can do is block those sites that are already bound by the histamine. So once they are bound to the receptor site, H1 antagonists block or prevent the adverse consequences of the histamine stimulation, like the vasodilation that we talked about, increase in respiratory and gastric secretions, and also that increase in capillary permeability. So as mentioned, these drugs can't push already bound histamines off the receptor sites, so these drugs are more effective in preventing the action of the histamine if they're given earlier in treatment, of course, because they can't reverse what has already happened, but they can stop what is continuing to happen so it doesn't get any worse. Alright, so the next few slides I just want to briefly compare the effects of histamines versus antihistamines on the various systems. So for the cardiovascular or small blood vessels, histamines will dilate and increase permeability, allowing substances to leak into the tissues. And this can cause things like hypotension and edema. The antihistamine effect would be to reduce that dilation of the blood vessels and reduce the increased permeability of the blood vessels. For smooth muscle or exocrine glands, they stimulate salivary, gastric, lacrimal, and bronchial secretions. So that's what histamines will do. So histamines will then reduce those secretions all around, okay? Circulating histamine molecules also bind to the histamine receptors on basophils and mast cells, stimulating them to release histamine stored within the cell as well, which will result in allergic reaction. Antihistamine effects, they bind to the histamine receptors again, even in these mast cells and basophils, which then prevents the histamine from causing that response. In the skin, there's reduced capillary permeability and a wheal formation. Sorry about that, a little bit of an interruption. So in the skin, there's reduced capillary permeability, and then there'll be a wheal or a flare formation. So that's where you're getting that those hives on the skin as well, and it'll cause itching. As for the anticholinergic effects that antihistamines have, they have a drying effect that reduces nasal and salivary and lacrimal gland secretion, so that runny nose, tearing, and itching eyes as well. And then some antihistamines, like I said before, can cause drowsiness. So sometimes these drugs are used as sleep aids as well. So antihistamines are used for the management of nasal allergies and seasonal and other types of allergic rhinitis or hay fever, allergic reactions, motion sickness. That also can help with Parkinson's disease, and then, as mentioned before, they can also help with sleep disorders.
And then, of course, as mentioned before, antihistamines are very helpful and to help reduce the symptoms associated with the common cold. So they can help with that sneezing, runny nose, those kind of things, and then keeping in mind that it's palliative treatment. It's not curative, okay? And again, they'll do empiric treatment, meaning they'll treat what the most likely cause of the problem is based on the symptomology. So the usual complaint is drowsiness when taking antihistamines, although there are many drugs on the market now that are non-sedating. Then there are the anticholinergic or drying effects they can also cause, so the dry mouth, difficulty urinating, constipation, or changes in vision. So you would want to be super diligent about your assessment here, because when you're going to give an antihistamine, it would be important to know if people had things like urinary retention, because these drugs could definitely exacerbate the problem. And then, of course, we already talked about that drowsiness that they can cause as well. There are two types of antihistamines: traditional, which have a sedative effect. They are used for allergic disorders, insomnia, motion sickness. An example of this would be like Benadryl. And then the non-sedatings, which, as implied by the name, they just don't have that sedating effect, and that would be like Claritin or Loratadine. That's a common non-sedating antihistamine. And these ones are used for allergic rhinitis or chronic urticaria. So non-sedating peripherally acting antihistamines, they were developed to eliminate the unwanted adverse effects, mainly the sedation. They work peripherally to block the actions of the histamines, so they have fewer of those central nervous system adverse effects because they don't readily cross the blood-brain barrier. I can talk eventually here today. They also have a longer duration of action. So again, when things work better and we have to take them less often, there's increased compliance in taking them. So these drugs are usually only taken once a day. Some examples of this would be fexofenadine or Allegra, Loratadine or Claritin, and then Zyrtec as well. So the traditional antihistamines, these are the older drugs. They work both peripherally and centrally. They have anticholinergic effects, making them more effective than the non-sedating drugs in some cases. They're also less expensive. They're available, most of them, over the counter. Some examples, again, are Benadryl or diphenhydramine, Phenergan, Meclizine, those kind of drugs. So what are the nursing implications? So we want to gather data about the condition, all of their signs and symptoms, what's going on with their allergic reactions, or have they had allergic reactions that required treatment in the past. We also want to assess for other medications that they might be taking, past medical problems, because sometimes, a little bit later we'll talk, there are contraindications sometimes to taking these types of medications as well. So they are contraindicated in the presence of acute asthma attack or lower respiratory type of diseases, such as pneumonia. These will require a more rapid-acting bronchodilator like albuterol. You want to use caution if they have increased interocular pressures, any type of cardiac or renal disease, high blood pressure, asthma, COPD, peptic ulcer disease, or pregnancy. And as many of these have anticholinergic effects and other effects, they can really increase the complications for patients that have these types of problems. We want to instruct the patients to report excessive sedation, confusion, hypotension. We want them to avoid driving or operating heavy machinery, and advise them about not drinking or using any other CNS depressants, because just like other drugs, if we take two like drugs, it's going to increase what happens. So here, or increase the effects. So here, it could increase that sedation and cause big problems. We also want to have them not take these medications with other prescribed or over-the-counter medications without checking with the prescriber because of the potential of serious drug interactions that can happen. These medications are best tolerated with meals to reduce GI upset. So food may definitely slightly decrease the absorption, but the benefit of reducing the GI upset is more important. If they do experience dry mouth, we can talk to them about using frequent mouth care. So chewing gum, sucking on hard candy, obviously sugarless would be preferable, and that can help to ease the discomfort. And then we want to monitor them to see if we are getting to the therapeutic effects that we intended. Now we'll talk a little bit about nasal congestion, and this is due to excessive nasal secretions in inflamed and swollen nasal mucosa. And this is usually caused by allergies or upper respiratory types of infections, or, the common cold. There are three subgroups of nasal congestants that are used. Adrenergics, this is the largest group. Then anticholinergics, which are less commonly used, and then corticosteroids that are also used as well. These drugs can be taken orally, which will produce a more systemic effect, or they can also be taken or administered topically to the nose or through a nasal inhalation. Oral decongestants have a delayed onset because the time that it takes for your GI tract to absorb them, but they also have a prolonged effect, and they don't have the problems of rebound congestion associated with that rapid absorption of nasal sprays. They also are exclusively adrenergic, so they induce vasoconstriction of the blood vessels in the nose and throat and paranasal sinuses, which results in a reduced inflammation and also reduced mucus formation. An example of this would be Sudafed. Topical adrenergics have the same effects as the orals, but they have a more rapid onset, and then they don't work as long. They also cause rebound congestion, which occurs because of the very rapid absorption, followed by the rapid decline in the therapeutic activity. And then this can lead to overuse of the nasal sprays, again, because they're not working as long and they don't have that sustained efficacy. So people will tend to use them more, and then they'll have that rebound effect, making things worse. An example of topical nasal decongestion, again, would be neosynephrine. And then intranasal steroids and anticholinergics are are not associated with the rebound congestion, and they're usually used prophylactically to prevent nasal congestion in patients with chronic upper respiratory symptoms. Some of the common steroids that you'll see are Nasacort is probably the one I see the most often, that and Flonase. There's Rhinocort, Nasalide, Beckinase, Omneris also is another one. And then intranasal anticholinergic, the only one that's on the market right now is Atrovent. So the anticholinergics work by constricting small blood vessels that supply the upper respiratory tract structures, and as a result, they shrink all of those small vessels, and then the secretions in the swollen mucous membranes are better able to drain, so it makes things a little bit better. So the site of action for these are the blood vessels surrounding the nasal sinuses. So just like any other steroid, these nasal steroids that are used exert their anti-inflammatory effects, which work to turn off the immune system cells involved in the inflammatory response. So these then again will decrease that inflammation, resulting in decreased congestion. So nasal decongestants are most commonly used for their ability to shrink that engorged nasal mucous membranes, and then also to relieve nasal stiffness. They're used to relieve nasal congestion associated with acute or chronic rhinitis, the common cold, sinusitis, hay fever, and other types of allergies. These nasal decongestants may also be used to reduce swelling in the nasal passages and to facilitate visualization of the nasal and pharyngeal membranes that, right before surgery or diagnostic procedures. And then I just want to talk a little bit about contraindications. So the adrenergics are contraindicated in narrow angle glaucoma, uncontrolled cardiovascular disease, hypertension, hyperthyroidism, prostatitis. I mean, the list just kind of goes on and on. Cerebral vascular accidents, TIAs, long-standing asthma, BPH, diabetes, cerebral atherosclerosis. So you can see that careful assessment while taking the history part of your assessment is going to be really super important. So for adverse effects for the adrenergics, there's some of the side effects are nervousness, insomnia, palpitations, and tremors. And then the steroids, local mucosal dryness and irritation. Systemic effects can be caused by those adrenergic stimulation of the heart, blood vessels, and the central nervous system. So that's where you're finding those problems with the adrenergics. So decongestants may cause hypertension, palpitations, and CNS stimulation. So you really want to avoid people taking these medications if they have these conditions. I mean, if you look at all that laundry list of contraindications, you would understand why you wouldn't want them to have, if somebody already has problems with hypertension, we don't want them to have nervousness and palpitations along with it. So it can really exacerbate or make problems a lot worse. So we really, really need to check, what are they taking, what are the over-counter drugs they're taking, and all of those things to make sure that we're not making the problems worse. And then, as always, we want to assess for drug allergies. Again, looking at the side effects for adrenergics, nervousness, insomnia, palpitation, it makes sense that the patient should avoid caffeine, as caffeine can make all of these types of symptoms worse. And because of the steroid affects the immune system, patients should be taught to report things like fever, cough, or other symptoms that last longer than a week, because these can indicate that something more serious is happening. Remember, we're kind of reducing the immune response, so we want to make sure things aren't turning into something else because our body doesn't have that same capacity to respond. And then patients should also be instructed to increase their fluid intake, and this can help liquefy and break up secretions. So we'll talk a little bit about cough. So respiratory secretions or foreign objects that are naturally removed through cough. So the cough reflex induces coughing or expectoration, or getting things out. This is initiated by irritation or sensory reception in the respiratory tract, and then those receptors are stretched, and then a signal is the cough center in the medulla of the brain, which then stimulates the cough. So a cough can be productive and have secretions, and those secretions would then be expectorated through the cough, or they can be non-productive, or they could have a dry cough with no secretions. So most of the time coughing is beneficial. It removes the excessive secretions and removes potentially harmful foreign substances, but in some situations coughing can be harmful, such as just after surgery, like a hernia repair, because remember we talked that coughing can increase that intra-abdominal pressure, so there are some cases where we don't want folks to be coughing. Antitussives can be opioid or non-opioid, and these drugs can reduce or stop coughing. They are also used for non-productive coughs and for coughs that may be harmful, again, like in those cases of abdominal surgeries or hernia repairs. Opioids can also, in addition to suppressing cough, they also can provide analgesia and have this drying effect on the mucosa, which will increase the viscosity of the respiratory secretions. So this will help to reduce symptoms such as runny nose and post-nasal drip as well. And these work directly on the cough center of the medulla. Example of this would be like codeine or hydrocodone. So you'll see that codeine in the Robitussin AC or the Dimethane DC. And then the non-opioids, they work completely differently. Dextromethorphan is a non-opioid antitussive that is a derivative of a synthetic opioid, levophenol. So in this case, because it is a derivative of an opioid, it will work the same as the opioids, but it does not have the analgesic properties. So this one will work the same. Now the other one, the Vicks Formula 44, Robitussin DM, that is the one that will work that way. And then there's other ones like the Tessalon pearls, and these ones work completely differently, like I mentioned at the beginning. So these ones suppress cough through numbing those stretch receptors that we talked about in the respiratory tract, so then it doesn't stimulate the cough reflex in the medulla. So I think I said that fairly confusingly, so I'm just going to say, reiterate what I'm saying. So for the non-opioids, there are two different ones. So the Tessalon pearls, these ones work completely different from the opioids, from stopping that stretch receptors or numbing the stretch receptors. And then the ones like Robitussin DM, that dextromethorphan, this one is much like, works exactly like the opioids because it's a synthetic, but it just doesn't have that analgesic property. Okay? If that's too confusing, you can let me know and I'll explain it in further detail face-to-face. Excuse me. So antitussive, these drugs are primarily used to stop the non-productive cough or that harmful cough. Contraindications for these drugs are listed on page 583 in your book. Excuse me again. So you can take a look there just to kind of check them out because they vary. Signs and symptoms vary depending on the drug. For benzonatate, there's dizziness, headache, sedation, nausea, and some others. The dextromethorphan, dizziness, drowsiness, nausea, and then the opioids have that sedative effect, nausea, vomiting, lightheadedness, constipation, all the things that you would see with opioids generally. So you want to perform a complete respiratory assessment and assess for allergies. You also want to obtain vital signs, including a pulse oximetry. You want to instruct the patient to avoid driving, again, or operating heavy equipment because of the possible sedation, drowsiness, or dizziness that can occur. You want them to report symptoms like a cough that lasts more than a week, a persistent headache, fever, or rash. Antitussive drugs are, again, for non-productive coughs, and you want to monitor them for their therapeutic effects. So expectorants, these drugs aid in the expectoration or removal of mucus, so that coughing up and spitting it out. They reduce the viscosity of secretions and then disintegrate and thin secretions. Guaifenesin or Mucinex is the most common expectorant, and it can be found in most over-the-counter cold and cough types of preparations. So expectorants work one of two ways. They either work on the reflex stimulation or direct stimulation. Either way, the final result is that there are thinner mucus and that it's easier to remove. With the reflex stimulation, the drug causes irritation in the gastrointestinal tract. Loosening and thinning of the respiratory tract secretions occurs in response to this irritation of the gastrointestinal tract. With direct stimulation, the gland that I can't even pronounce this today, sorry you guys, secretory glands are stimulated, and then directly to what happens is that when they are stimulated directly, and then this will cause the production their production in the respiratory tract fluids. And again, when we have more fluids, that will loosen up and thin the mucus. So by loosening and thinning the sputum and the bronchial secretion, the tendency to cough is also indirectly diminished. So these drugs are used to relieve the productive coughs associated with common colds, bronchitis, laryngitis, pharyngitis, coughs caused by that chronic postnasal sinusitis, pertussis, influenza, and measles as well. Adverse effects are pretty minimal. Guaifenesin may cause nausea, vomiting, and gastric irritation. So expectorants should be used with caution in the elderly and for those with asthma or respiratory insufficiency. Patients taking expectorants should receive more fluids if permitted to help loosen and liquefy secretions. You want them to report fever, cough, or other symptoms that last longer than a week. And then you want to, again, monitor them for the intended therapeutic effects. And then just briefly, your book talked about a couple of herbal products. So echinacea is believed to have an immune stimulant effect, so it's used to help reduce symptoms of the common cold and reduces recovery time. Adverse effects include like dermatitis, GI disturbances, dizziness, and headache. There is also information in your book on, I think it's page 577, and it's on golden seal. And this herbal supplement has been shown to have like antibacterial, antifungal, antiprotozoal activity, along with some anticholinergic and antihistaminic activity. So they can be helpful in the treatment of upper respiratory infections, allergies, and nasal congestion. Then adverse effects include GI distress and emotional instability. So again, if you have any questions, you can post these questions in the discussion forum under questions. You can also email me or text me, and we will have time definitely to answer some questions in class. Please contact me if any of this was confusing or you need any help with clarification. Thanks.